My name is Lilo Blank, and I will be presenting my project on the motivation, self-determination, and access of care among drug court-involved women, and I will be doing so using a sequential and mixed methods approach utilizing 2 studies. So a little bit of background about drug treatment court. Drug court acts as a collaboration within the justice system to facilitate participation in substance use treatment programs. And drug court has a particular focus on rehabilitation as opposed to retribution, and a focus on community engagement as opposed to incarceration. It has been shown effective in reducing drug-specific crime, as well as overall recidivism. So women in drug court specifically experience gendered pathways to crime. This is due to the criminalized pathways of drug use and sex work that lead to justice involvement. Additionally, women are more likely to have experienced physical and sexual trauma and struggle with mental health disorders when compared to their male counterparts. And so there are specific unmet needs of justice-involved women. So a little bit of background about the framework that we use, which is self-determination theory. Self-determination theory posits that there are 3 basic psychological needs that are supported, promote psychological and physical well-being. And the 3 tenets are autonomy, relatedness, and competency. Autonomy describes the degree to which an individual feels able to initiate self-endorsed decision-making. Relatedness describes the degree to which an individual feels able to connect with their social networks, their peers, their family, and their justice system network. And competency describes the degree to which an individual feels able to accomplish their goals. And we used a specific sub-theory within self-determination theory called organismic integration theory. And this describes the internalization of external forces of motivation to internal forces of motivation. So self-determination theory within the justice-involved women population. Women face stigmatization that they may internalize due to the behaviors that lead to their justice involvement. And they may face additional stigma due to their HIV or hepatitis C status. And this self-stigma may restrict access to care in initiating self-help behaviors. And so the objectives for study 1 and study 2, there is very little literature regarding hepatitis C in the DTC involved women population. And so this project seeks to address this particular gap. And so together these studies fill the gap between the justice system and the healthcare system and provide a preliminary basis for using self-determination theory frameworks to promote self-help behaviors. Just as a little disclaimer, I was not involved in study 1, but it sets the stage really well for study 2, which I was involved in. So the study 1 hypotheses. Authors predicted that self-determination theory measures would yield an acceptable internal consistency, show a preliminary consistency amongst the 3 basic psychological needs, and this was done in a one-time data collection. And additionally, the authors predicted a participant willingness to engage in future study. So the methods for study 1. A sample of 79 women were recruited from the Monroe County Drug Court. Women were deemed eligible if they were over 18 years of age, assigned female sex at birth, and drug court involved. The women completed a 5 to 10 minute self-report questionnaire, and they were compensated with a $10 gift card for their time. It was determined by the IRB that consent was not necessary because the only thing that would connect the participants to the study would be the consent form itself. And so participants were given an information sheet that described the scope of the study as well as the protections because justice-involved individuals are considered a vulnerable population. And so both studies 1 and 2 utilized the same self-determination theory measures. The first was the treatment self-regulation questionnaire, which assesses why people choose to engage in healthy behavior change or maintain healthy behaviors. The perceived competency scale, the PCS, which assesses the degree to which an individual feels competent to maintain or change their behaviors towards a healthy set of behaviors, and the Healthcare Climate Questionnaire, which measures the degree to which an individual feels that their autonomy is supported by their social networks. And these measures have been shown reliable and valid in other population settings. Our results show a reaffirmed viability for the recruitment strategies that were used in study 2. Women were willing to engage in interactions requiring sensitive topics concerning their healthcare statuses, such as their HIV or hepatitis C status, their substance use disorder, or their use disorder of alcohol and other drugs. So results showed that a diverse demographic of women who were screened were willing to participate in future studies, and measures yielded an initial internal consistency with a reliable set of alpha scores. I would like to point out something that was of particular interest to the gap in literature. I'd like to point to the prevalence of self-reported hepatitis C amongst women screened. 12.3% of women screened self-identified as having a hepatitis C infection, and this is 12 times higher than the general population, which rests at approximately 1%. Additionally, 9.2% of women screened identified a need for additional hepatitis or HIV care. And so this well sets up the second study. So the model that was used for the first study, this shows the interrelationships between the self-determination theory measures used. And so it essentially says that the measures were interconnected. So support in one domain led to increased levels of need satisfaction in the other domains. For example, as perceived autonomy support from case managers increased, so too did levels of perceived competency and in turn levels of autonomous motivation. And so just in summary, study 1 provided reaffirmation of the recruitment strategies that were ultimately used in study 2. It supported the existing literature regarding the acceptability of self-determination theory measures and reaffirmed the need for additional HIV and hepatitis C care to the benefit of justice-involved women. Moving on to the second study hypothesized a positive relationship between participation in the intervention and a trajectory towards autonomous motivation. It additionally sought to validate study 1's measures further and assess participant adherence to the self-determination theory framework and motivational strategies. The methods of the intervention. The second study recruited similarly from the Monroe County Drug Court and screened 115 women. 25 were deemed eligible, 22 were enrolled, 15 women engaged in the study, and 11 completed the intervention to satisfaction. Women were given a HIV or hepatitis C or a quick rapid test and were provided with their results within 30 minutes of their screening by a research team member. And they completed a self-questionnaire using the audio computer-assisted self-interviewing ACASI system. Women were deemed eligible if they were over 18 years of age, drug treatment court involved, and had a preliminarily positive test result for HIV or hepatitis C. The women were consented and compensated over a graded scale throughout the intervention for a cumulative of $255 for complete data. Our intervention manual was adapted from the smoking cessation manual by Jeff Williams and the motivational strategies manual by Milner and Rolnick, and was adapted particularly for this population. And the intervention procedures themselves comprised of 6 biweekly 60-minute intervention sessions with either the principal investigator or peer interventionist. And women were given the scope of the intervention, which was whole women's health, so mental health, physical health, trauma history, and safety from intimate partner violence. And just to touch on the quantitative side, statisticians ran a fixed effects regressions model to test the statistically significant intermeasure relationships between the self-determination theory framework measures. And these same measures, just once again, were used in study 2 as study 1 and adapted for its purposes. For our demographics results, most of the women who enrolled in the study self-identified as Caucasian, and this is just indicative of the sample that we had. And 63% had a comorbidity of smoking, which supports the literature that shows an association between substance use disorder and smoking as a form of coping mechanism. And so moving on to the TSRQ, the Treatment Self-Regulation Questionnaire. This set of results shows the continuum of internalization towards external forces to internal forces and reaffirms organismic integration theory. So it was a very positive set of initial results that women had a positive trajectory towards autonomous regulation regarding their smoking cessation, accessing HIV or hepatitis C care, and regarding their substance use disorder. And so within the perceived competency scale, perceived competency for HIV and hepatitis C care was associated with perceived competency for substance use disorder, which was in turn associated with perceived competency for smoking cessation. And so perceived competency is related in many areas. Similarly, within the Healthcare Climate Questionnaire, perceived autonomy support from peers and family was associated with perceived autonomy support from the DTC judge regarding the participants' healthcare and ability to make healthy behavior change. And between the TSRQ and the PCS, perceived competency support regarding HIV or hepatitis C care and substance use was associated with participant motivation to make healthy behavior changes. And between the TSRQ and the HCCQ, perceived autonomy support by case managers and peer interventionists was positively associated with motivation to make healthy behavior change as well. And so the implications of the study, the TSRQ measures reflect a content validity for assessing the degrees of internalization regarding health-related behaviors such as smoking cessation, access of HIV or hepatitis C care, and substance use disorder care, as well as sobriety from alcohol and other drugs. The results also support previous literature and show face validity that supports the notion that self-determination theory-based interventions are similar within the context of drug treatment court-involved women. Self-determination theory-based interventions may be effective in changing health behavior since constructs positively impact the three basic psychological needs. And because intervention participants showed a general positive trend towards internalization for all health-related behaviors, facilitating interpersonal connections with peer interventionists may have a positive contribution to client motivation to access HIV or hepatitis C care. And so a little bit about the limitations of the studies. For the first study, due to the nature of self-report, some data may be biased. Additionally, some women were living unaware of their HIV or hepatitis C status when they were screened, and we unfortunately did not have the opportunity to rapid test them. And for study 2, our peer interventionists facilitated sessions uniquely, and so outcomes may be in part due to the variation in intervention style. Finally, ironically, due to the structural obstacles that restrict women's access to care in the first place, women who engaged in the study faced similar barriers to participation, and this restricted our ability to access behavioral outcomes, and so our results are strictly motivational. Together, these studies may be used to inform larger scale studies that address internalized motivations and access to care amongst drug court involved women with comorbidities of substance use disorder and HIV or hepatitis C. And I would just like to give a very, very big thank you to Dr. Diane Morris, who has been my mentor and support throughout my last 4 years of education. I would like to give a big thank you to the rest of the WISH team and Precious Bedell, who has been a strong support and mentor to me as well. I would like to thank Dr. Christopher Nemec for acting as my second reader, and I'd like to thank my friends and family. And here are my references. And are there any questions?